Okay guys, so we have our discussion today, and that will be the last lecture of upper limb. So far we have tried to cover up, and the whole upper limb is designed to control the hand. And hand is one of the most complex and most delicate machine ever made, ever raised, ever born in this world. And so much important is occurring here that still we are, despite of so many technologies, so many innovations, still there are so many facts and figures and features which needs to be explained, which needs to be resolved. So this is a complex area of understanding. So many important structures are closely going and packed. I need your full attention, because if you don't make proper appreciation of the structures which are evolved here, there it'll become difficult. I'll try my best, and I'll try by saying one simple verse from Quran, and that says, قَالُوا سُبْحَانَكَ لَا عِلْمَ لَنَا إِلَّا مَا عَلَّمْتَنَا إِنَّكَ أَنْتَ الْعَلِيمُ الْحَكِيمُ. I'm nobody, I'm nowhere, and still I'm nowhere. The one who made, one who created, he knows everything. So, with this beginning, I want to proceed with, and let's start learning the hand, the human hand. So, why we have it? Why we need it? Primarily, as I explained, for manipulative functions, and these functions are powerfully and precisely controlled behind the power grip and precision. So these are the two things that we need to show our muscles, and we need to be pinpointing, and that is the sole objective of our hand. And that makes it, to get this power and precision in one unit, that makes it very complex. It has so many integral things. So power and precision grip, there is a description for that, but I have explained in few words. Now coming to the dorsal digital expansion, the extensor hoods, we talk about it. And that's important, and we have some idea that what is happening, how the extensor tendons have been kept in control while moving, while bringing extension at different joints of the hand. So now with this, I'll go to this X-ray image where you are looking at an X-ray of the hand. And this X-ray of the hand is revealing to you the different bones. And let's start labeling it. I hope people know these names, and people have been gone through this process. Is there anything which needs your explanation? Yes, thank you very much. So these are together known as the carpal bones. And then we had metacarpals, but we need to know they have a base and a head. It's a miniature long bone. And you can see them. There I have proximal, middle, and distal phalanx. And we have these phalanx. We don't have middle phalanx in the thumb. Is that clear? And there you are looking at a sesamoid bone, which you have seen is present just at the proximal phalanx on the first digit. Is that clear?
Does that exist in everything?
It depends how much you are using it. But thumb is a quite movable and integral structure in human hand. And if we minus thumb, trust me, hand will never become functional. And we need to implant, we need to transfer the index finger in place of the thumb, and we have to do it if you want functionality available at that hand. And that is a required, that is a major undertaking, is a massive type of surgery, and that has, again, its outcome, it dependent on the person who's doing it and what are the resources and the situations available to him. It's a long procedure. But this is something to be done to bring someone a functional hand. Obviously, it will not be as good as it has been created, but we can come close to a little bit functional perspectives. Now, this slide we have discussed before. Today I'm discussing it with more emphasis, and there you are looking at the inside parts of any digit. And we all know that we had metacarpals, and then we had proximal phalanx, middle phalanx, and distal phalanx. Is that clear? Going further, a joint between the metacarpal and the proximal phalanx is MP joint, and what is this MP joint? Is metacarpophalangeal joint. Is that clear? This one is between the proximal phalanx and the middle phalanx, and this joint is called proximal interphalangeal joint. And then we had between the middle and the distal, so we call it distal interphalangeal joint. So these names expected to be clear with you. Please don't quote DIP, MIP, MP and P1 and P2 and P3, because people might not be good with these type of infos. So now the extrinsic muscles, and ultimately you are looking at the tendon of extensor digitorum, and that we all know. We all learned this before. This tendon is going to be attached onto the dorsal surface of the base of the distal phalanx. Is that right? So this is my tendon of extensor digitorum, and the pull is backward direction, and that lifts up, that opens up a fist. If it's closed, when this extensor digitorum works, it opens it up. So it goes backward, and the final movement is upward. As you can see, is shown here, upward, and then it goes backward. And then to keep this tendon in its position, we need to have certain players, and we are provided with dorsal digital expansion. And the role of this expansion is to stabilize this tendon attached throughout to the length of the digit and maintain it in its position while it's functioning. Is that clear? Then you are looking at now on the flexor side, and you are looking at a counterpart muscle, and that is my flexor digitorum profundus, and that is going to the base of the distal phalanx, same like extensor digitorum. And then this flexor is being reinforced by another muscle, and that is my flexor digitorum superficialis. You have seen it. While it's going to be attached, it splits in two, and it goes to the bases of the middle phalanx, and it gives way to the freeway to the passage of the profundus tendon, so it can pass through and it can reach to its destination. Is that right? And these muscles are counterpart. As I said, to make a grip, to make a fist, we are using more power. We need more power. We need stronger thing, because we have to do some job. Extension is just an opening, but flexion, and outcome of flexion is too much force is required to be exerted to get all that in a line, so that we need a powerful flexors. And then we can see that how the direction is, and once we contract these muscles, these tendons, so the fingers are going downward and we are making a fist. So power flexion and power extension, you have seen how and in which direction they have to be demonstrated. We need more power in flexion. So they are the precision intrinsic muscles, and we had extrinsic muscles, and they are for power. So primarily the extrinsic muscles are outsider muscles, kharji, and intrinsic muscles are dakhli, local. So intrinsic muscles are primarily responsible for precision. Now let's talk of what is power and what is precision. Power, you are lifting some heavy thing, you are hanging with some heavy object, you are throwing something, you are holding something, you are twisting something, that is power. Precision, you are doing some fine delicate work, like you are putting a thread in a needle head. You are doing some exclusive type of surgery, some very vital organ like eye. You are working it so delicately. So that is precision. You are playing your musical instrument. That is a precision. That is not a power. You don't need power there. You need a flick of the action, and that give you the movements which are desirable. Got it? So that is the difference between precision and power. And intrinsics are primarily responsible for precision, and extrinsics are responsible for giving us power. And we need to have combo of all that. Is that clear so far? So now my flexor tendons, and there now you can see something which is coming up. There is something Can you see this? This structure? So this structure, which is going upward, it's coming from a bone and going to a tendon. So this structure is an interosseous muscle. It is a category of intrinsic muscle. Interosseous. We have interossei on the dorsum of the hand. We have interossei on the palmar aspect of the hand. So on the both sides of the hand, we have interossei. Those who are on the palmar side, we call them palmar interossei. Those who are on the dorsal side, we call them dorsal interossei. Interossei, they to the bones, but they are coming from a tendon, and they are coming from a bone, and they are going to the tendon. Is that right? There is another group of muscles. Now you can see that they are emerging from a tendon, and they are going to a tendon or to its expansion. And these muscles are the lumbricals. So there you are looking at the lumbrical, and this one is the interossei. So lumbrical is coming from the tendon of flexor digitorum profundus, and it's going towards the extensor hood, the extensor digital expansion, to be attached, to be reinforcing. So from flexor to extensor, the power has been shifted, or from extensor to the flexor, the energy has been generated. That explains so many things which apparently not resolved. When we talk of ulnar claw, there are little separations, and we don't know the exact mechanism why it happens. So once we have established the lumbricals, how they are working, once we are good with the understanding of the action brought by these lumbricals and these interossei, they will explain us how these actions have been achieved, how we have an ulnar claw, why it's different from the median claw, and what are the different things which are occurring at different levels. Is that clear? So you are expected, and you need to be good. I'm not saying good, need to be best with the understanding of the actions which has been created by the lumbricals and interossei. Interossei, their actions are simple. We will be dealing them shortly. So the lumbricals have been shown. Now this is the axis. This black thing, again, understanding the axis of the movement is important. If I know the axis, I can very easily understand what is happening. If I don't know about axis, probably I'll be suffering. And remember, these images, these pictures are not 3D. So it is difficult. But once you get some 3D thing, you can understand things in a better way. So now, what are the functions and what is happening by these muscles? It has been explained on this upper corner. So now these boxes which are appearing here, they are a little bit tricky. If you understand them, you may have understood the whole mechanism. So at one place is showing flexion, then extension, then extension. Who contribute in making a hand? We have done it on the X-ray, just a revisit to the slide. So I'm not paying too much attention to that. So it simply says hand contains around 27 bones. It's not about 1 and 2. There's a big number of bones. They are here. But what you can see here, in front of the scaphoid, this sign is for a fracture. Hash you call it for when you're putting for your iPad or your iPhone or something like your smartphone. But this hash is in medicine, in clinic. This is a sign for fracture. We don't write F-R-A-C-T-U-R-E. We just radius, 4 lines, means fracture of the radius. So this is fracture for this. We use it for fracture, and it's not used for today for many years, maybe 1,000 years or whatnot. Now, why I put this fracture sign in front of this bone? Because out of these carpal bones, it has been seen, if we take the fractures of the carpal bone, the most commonly fractured bone in the carpals is the scaphoid. The one who's number 1 is the scaphoid. Then I have other bones, we know their names, and now there is lunate. And in front of lunate, you can see that it is mentioned the one of the most dislocated bone, the one which is more vulnerable for dislocation. So one bone is for fractures and the other bone is for dislocation. If someone doesn't tell you, someone fall on outstretched hand, result in a dislocation occurring in the carpal bones, even if someone not mentioning and asking you, can you show it in this X-ray? So you should start thinking first the lunate. When we talk of fracture, start thinking first the scaphoid. If a fracture happens to the carpals, the first to be affected must be the scaphoid. Clear? Now, going further, these are the further bones. So after knowing these names, we all know they are the carpal bones. And the joint here between the lower end of the radius and these carpal bones, to whom we call it as the wrist joint, that is my radiocarpal joint. And there we are looking at the metacarpals, and then we had the proximal, middle and distal phalanx. Is that right? So these are phalanges, and these are the joints, carpo-metacarpal joints, and then we have metacarpophalangeal, proximal interphalangeal and distal interphalangeal joints. So these are the joints which are there, which we need to know when we are learning the hand. Is that right? Now going further, again to an X-ray. Now I'll build on a hand. I'll start constructing a hand, and I'll start from this sketch, and I'll go up till the skin. So this transition from the bone to the skin, we'll be learning it. Through our journey, we will see the ligaments. Then after the ligaments, we'll see the muscles. Then we see the arteries, we see the nerves, then we see the muscles. And ultimately, having some epineuritis, and then we'll be finishing with the skin. So the journey begins with that. We had 1 to 5. So who's number 1? We had preaxial and postaxial borders. Why we are saying that? Because we know that developmental things. We know which is 1 and which is 2 and which is 5. Is that clear? And what are their exact names? Scientific names, anatomical names. Pollex, indicis, medius, annularis and digiti minimi. These are their scientific names. Right? Now this is the axis. You can see your hand. You cannot, so around this axis every movement is occurring. You can spread your fingers, you can bring them together. But the central finger, the middle finger, your medius is not moving. That is static. And that around that every movement is occurring. So this dotted line represents the main axis of our hand. So this is the axis and midline of the hand. And everything is lateral or medial with reference to this midline. These are the carpal bones and these are the metacarpal. And then we know it, where is the head and where is the base. Clear? Now, we know this joint. We talk about these joints. Clear? Now, let's start. So the bones are done. Now let's start putting the ligaments here. So the ligaments of the hand, we have, can you see these capsular ligament? Capsular and collateral ligaments, they are visible. And now what are these white things? These are palmar ligaments. They are plates. If you don't remember them, nobody cares. Okay? So don't stress out for them. But good to know is fine, but not must to know. And these are deep transverse metacarpal ligaments. And there we have tendon of flexor digitorum superficialis. We know how it is attached. And we know how the tendon of profundus passes through it. And how it goes to the distance. And there you are looking at, we learned yesterday some of these ligaments. Palmar carpometacarpal ligaments and palmar metacarpal ligaments. These are the ligaments which are existing in the lower part. Now let's start bringing further structures here. These are my introssei, and you are looking at first dorsal introssei, second, third, fourth. These are my introssei. So introssei, dorsal introssei. Dorsal introssei visible from the dorsum. I put a word DAB in bracket. What does that mean? D goes for dorsal and AB goes for abduction. So dorsal introssei are designed for abduction. So this action is being brought by dorsal introssei. If you want to check someone, if you want to check on someone, his dorsal introssei are working, ask him to do that. You want to check the power? Put your fingers here. Ask him now, apply the pressure against your resistance. So you can figure out, is it a powerful abduction or is a very weak type of abduction. So that demonstrates how strong and how good is the nerve supply and how good is the spinal cord of this particular person. Is that right? So the action of the dorsal interossei is to bring about abduction. And the palmar interossei, their job is to bring about adduction. So they are opposite to it. So now this pink thing, these are my palmar interossei. So they are visible from the palmar side. The first one I have not shown because of technical things. Is it clear? Now, who is this artery? Radial artery. Why we call it radial artery? We see that it is on the radial side. Don't say thumb. So it is emerging on the radial side. Excuse me, gentlemen. You are sleeping and I can see 2-3 more sleeping. Why? I told you today get some coffee. You need extra energy. So, the radial artery, and what it has done, it has piercing after going through the anatomical snuff box. It pierces my first dorsal interosseous muscle and it enters onto the palmar side of the hand. Now it is here. It is here for a job. What is its job? It contributes in making an arch, and this arch is the ultimate fate of these arteries, and these arch, they are supplying the muscles, skin, superficial tissue and cutaneous tissue in the palm. So there is, I have one which is within the muscle. I call it a deep palmar arch because it's on the palmar surface. So when I said I have a deep palmar arch, I must have a superficial palmar arch. Then I have a dorsal arch. So I don't need any superficial and deep on the dorsal side. So now you can see that it gives a branch, and there from this radial artery I have an artery which goes to my thumb, and thumb is what? Pollicis. So this one is arteria principis pollicis, or principis pollicis artery means the main artery for the thumb. Principis pollicis artery. And then you can see that another artery go for the index finger. So indicis artery, arteria indicis. Radialis indicis artery. These are digital arteries. They are going to these digits. Now you can see that this artery, after piercing this muscle, after giving these branches, now it turns towards this side of the hand, towards the ulnar border of the hand, and it makes a loop. It makes an arc. It makes an arch. It is deep. I call it deep palmar arch. Is that right? And there on the ulnar side, it meets the counterpart. Who lives on the ulnar side is the ulnar artery. Don't say radial again. Radial is here. How come radial can be on two sides? So this is my ulnar meets with the radial artery to give us deep palmar arch. And this deep palmar arch, it gives supply. It contributes to the thumb and to the one side of the index finger. Is that clear? Going further. So deep palmar arch is visible to you now. Now what is happening? Can you see a branch emerging from this ulnar artery? That is a deep branch from the ulnar artery. Now this is the ulnar artery proper. So you are looking at its deep branch and you are looking at its superficial branch. Now from this arch, deep arch, we have these arteries which are going forward. And these are palmar metacarpal arteries. On the palmar surface and running on the metacarpals. And there I am showing you a muscle. This is adductor muscle. Guys, when we talk intrinsic muscles of the hand, please don't get confused. Don't get confused. For thenar eminence and for hypothenar eminence, we have only 3 for thenar, 3 for hypothenar. Our old books, they talk of 4 and 4. Understand? This muscle which I am showing to you right now, it appears that the name says it is for the thumb, but this is not a thin arm eminence muscle. You can see that. By the way, tell me, what do you understand by the thin arm eminence? This is my thin arm eminence. And this muscle is not here. This muscle is coming from the midline. So why should I call it thin arm? Khalivali. It's not innervated by median nerve. Saeed, sleep. Ulnar nerve. Where are you? You took this lab. Thenar muscles are innervated by median nerve. So, this muscle, it doesn't belong to this group. It has to go to the thumb, but it doesn't belong to that. If I make 4 here, then I have to make 4 here. Old books, they talk of 4 muscles. And who was the 4th muscle? Was palmaris brevis. Palmaris brevis and adductor pollicis was for thenar and palmaris brevis was for the hypothenar. But now that era is gone. Now for thenar eminence, if you get this question in the exam and you ask what are the muscles here in the thenar eminence, your answer should be flexor, pollicis brevis, abductor, pollicis brevis and opponens pollicis. That's it, period. For the hypothenar, flexor digiti minimi, abductor digiti minimi and opponens digiti minimi, period. No palmaris brevis there, no adductor pollicis is there. Adductor pollicis is a muscle of the midline. It has a separate supply. Clear? So don't get deceived. Like, someone might have taught you this, but it doesn't mean that is the thing which you should carry on. So correct yourself. Yeah. My dear, before I can see your full question, deep arc is the baby of radial. Superficial arch is the baby of ulnar. Go with this concept. So deep arch made by the radial and it is held by the ulnar. Superficial arch is made by the ulnar. It may be helped, it may not be helped. It may be, it may not be. So radial may not contribute or it may contribute. But still we call it superficial arch. But for the deeper arch, the main source is the radial artery. So who's reinforcing there is the ulnar artery. Yes. Is that clear? Yeah. Can you see that? Can you see that, my dear? Tell me. I'll remove this for you. From where it's coming? My deep arch is here. You can say to a certain extent it's not a big deal. But apparently it looks more coming from the other source, from the radial. Are you clear with that? Any other question? Any other issue which is not resolved? Look, books have some differences. Don't get deceived by the differences. Go with what is in the mainstream. If you know a little bit extra, it will never help you. It will create problem for you. So go, Sida, Alatul. Obviously, pulse of the thumb will be caused by the artery which is there in the thumb. Right? So now going further, what is happening? Now let's see. So I'm putting here adductor pollicis and adductor pollicis, as you might have seen yesterday in the lab. Today, that this is the transverse head and it has an oblique head. And both of them are going to the proximal phalanx, base of the proximal phalanx of the first digit. And this muscle, now this adductor pollicis, it is also been pierced by the deep arch. So radial artery, it pierces the first dorsal interosseous muscle along with the transverse head of the adductor pollicis muscle. Is that clear? So then it's going towards, is crossing over, and then it's coming and joining with the ulnar artery. Now along with the ulnar artery, a nerve starts emerging, and the nerve who is emerging here, it is on the ulnar side, so we are born to call it ulnar nerve. Is that right? So ulnar nerve, and this is what I am telling you, it is the deep branch of the ulnar nerve. Ulnar nerve, when it approaches the hand, it bifurcates, it divides into a deeper part and a superficial part. So this is, you are looking at the deep branch of the ulnar nerve. Deep branch of the ulnar nerve and deep arch, deep palmar arch, they are going together. So that makes it a little bit more important to understand, and you can generate some MCQ here, some concern here. So they are going together. Is that right? Why it's going on that side? Because its job is to supply someone there. And who's that someone? Is my adductor pollicis. So let's see this deep branch, and there you are looking at now the small baby which emerged here. That is the superficial branch of the ulnar nerve. So the deep branch, it goes towards the adductor pollicis. You can see that it is supplying to its oblique head. Then it supplies towards its transverse head, and then it's going to the interossei. Dorsal interossei, palmar interossei, they all are supplied by the ulnar nerve. Clear? Adductor pollicis is also supplied by the ulnar nerve. And now you can see that there you can see the dorsal interossei, there you can see the palmar interossei. So their nerves are, all of them are coming from the deeper branch of the ulnar nerve. Is that clear? Is that visible? Now, who's this tendon? That is the flexor digitorum superficialis. So everywhere. So now, as I told you, I'll start my journey from a bone and I'm layering it up. So there you are looking at these tendons, they are going and they are getting attached to their destinies. And they are traversed by, and there you are looking at an individual muscle. This is my flexor pollicis longus. Clear? And there you are looking at the flexor digitorum profundus going through each of the superficialis. Is that right? So now, something interesting. From the tendon of, Uday, see here, don't talk. Look at flexor digitorum profundus. A muscle is emerging, coming from this flexor digitorum profundus tendon, and is going towards the dorsal digital expansion. So a shift from the flexor to the extensor has occurred. And this one is my first lumbrical. And this is my second lumbrical. So I have 4 lumbrical muscle. There is no palmar and dorsal. All of them are on the palmar side, and they are coming, they are attached to the tendons of flexor digitorum profundus, and their other end is not going to any bone, they are going to the dorsal digital expansion. So you are looking at 2 on the radial side. These 2 palmar and these 2 lumbricals are innervated by median nerve. And now my remaining 2 lumbricals, you can see that it is coming from the tendon of the middle finger and tendon of the ring finger, and then it's going towards the dorsal digital expansion. The third one, and the fourth one from the ring finger and from the pinky. So they are all going to, so these two lumbricals are innervated by ulnar nerve. Got it? So my radial lumbricals are innervated by median nerve, and ulnar lumbricals are innervated by ulnar nerve. Clear? Same like the tendons of my flexor digitorum profundus, the ulnar tendons, the tendon number 4 and 5 from the ulnar, and tendon number 3 and 2 are innervated by the median nerve. Any doubt with this statement? So these are the lumbricals. And now you are looking at flexor synovial sheets. They are just keeping these tendons lubricated. And now I have something extra. These things have to be fixed. So fibrous flexor sheets. And now there is something unusual for this flexor pollicis longus. It has its own sleeve, and that is continuous. So this sleeve is on the radial side. We don't call it flexor synovial sheath, we call it radial bursa. We call it radial bursa. And now I have not covered this pinky yet. I have something special for pinky. So that surrounds pinky here, my 5th digit, and then it surrounds these tendons, these remaining 3 tendons. And now this is on ulnar side. If you remember, when I've shown you a cut section, which was going through the carpal tunnel, you have seen there was a bursa. I mentioned that figure of 3, that this is the ulnar bursa. It is on the ulnar side. This is my radial bursa, this is my ulnar bursa. You need to be good what tendon are passing through the radial bursa and what tendons are passing through the radial bursa. This is important. Is that clear? Is it visible? So this one I call it ulnar bursa, which is on the ulnar side. And there, now I have showing up the median nerve. And median nerve, it enters the palm, it crosses the wrist joint, it crosses the wrist, it enters the palm, and you can see that it is dividing here. So median nerve is showing up, and median nerve is always goes under cover of flexor retinaculum. It goes under the flexor retinaculum. This is my median nerve. And there you are looking at, now you can see that the superficial branch of the ulnar artery starts going over. And even the deep branch was not going under the flexor retinaculum. That was outside, and this is above the flexor retinaculum. Is that clear? Now, you can see that this median nerve goes backwards. So that is, this coming backward, it has a name to it. Recurrent branch. Motor, this is a motor branch. Recurrent motor branch. And this recurrent motor branch is the one who will be supplying my thenar eminence muscles. Is that clear? So now, recurrent branch of median nerve. And now, you can see that this one is the motor component. But from this main median nerve, I have one cutaneous nerve, which is going towards the thumb. This is a cutaneous nerve. This carries sensory. It has no muscle, because no muscle is here. It is going to the skin. So this is from my median nerve. Again, median nerve gives to the radial side of the index, to the ulnar side of the index, to the radial side of the middle finger, so you are looking at the median nerve is contributing to the middle finger completely, to the index finger completely, towards the pollicis completely, and then partially towards the ring finger. So if I say the cutaneous supply, the sensory supply from a 3.5, how I say 3.5? 1, 2, 3 and half of this. So 3.5 sensory supply on the palmar side of the hand is being carried by the median nerve through its cutaneous or digital branches. Am I right by saying that?
Absolutely.
Say yes or no.
Yes.
Thank you, Mohammed. So now you can see these are called digital branches because they are supplying the digits. Now what is happening? Ulnar nerve, its superficial branch, it gives across the 5th digit and the remaining part of the ring finger. So 1.5, 3.5 and 1.5. That completes my digits. So you can see the contribution, the sensory contribution, and this superficial branch of the ulnar nerve, it also supply a superficial muscle of the hand, and that muscle is known as the palmaris brevis muscle. Palmaris brevis muscle has to do nothing with the hypothenar eminence. It's just a superficial muscle, and that gets its supply from this superficial branch of the ulnar. If I can say ulnar nerve, when it enters the hand, it divides into a superficial branch and a deep branch. Superficial branch, it gives a muscular part to the palmaris brevis muscle. Then it gives digital branches for the 5th digit and half of the 4th digit. Median nerve, when it enters the palm, when it reaches to the wrist, it goes under the flexor retinaculum, and then it reaches to the palm. There it gives a recurrent branch, and it continues as its superficial branches. The superficial branches, they are bound to supply my 3.5 finger, my 3.5 digits. First is my 1st digit, 2nd digit, 3rd digit, and 4th digit is partially. So that is the innervation by this. But this median nerve, when it is entering in under this flexor retinaculum, it gives another branch which is not shown yet. And this branch is now showing up here. You can see this branch. So median nerve, before going under this flexor retinaculum, it shows another branch, and that branch is the palmar cutaneous branch, and this branch is very helpful for establishing some diagnosis. Someone present to you with a median nerve injury. Now symptoms are similar. Let's say the nerve is cut here. The symptoms are similar to carpal tunnel syndrome. But should I go for a cutting of this thing or not? I have to decide. Even I cut it, patient will not get any benefit. Patient start fighting with me. He can sue me. Doctor, you are wrong. You said after getting this surgery, I will be fine. But nothing happened. My mother has the same problem. What you have done? The issue is, the reason is I have not paid attention to the neurological examination of this patient. I have not tested that nerve I was mistaken. Oh, blindly I am a big orthopedic surgeon, so I can say that yes, I can see that all what you're talking, I can see that muscle is decreased, the thenar muscles are becoming so atrophied, the sensations are not there, this is not there, blah is not there. So fine, you have the problem with the carpal tunnel. I will split this flexor retinaculum. After this, there will be improvement in the symptoms. You did the surgery, you charge money, you hospitalize the patient, and patient is not relieved. Patient is again banging your head again. Now you are in a big trouble. Now what to do? What has happened? What went wrong? You cannot swallow it. I did wrong. I made a mistake. Because you made a mistake. What was the mistake? Your job was to test for that. This nerve is damaged here or this nerve is damaged before. That was important. How I do that? We know that there is a palmar cutaneous branch here. So it means the sensory supply, even if the damage is in the carpal tunnel, if the pressure is in the carpal tunnel, this branch will not be affected. If I get the sensation here, I can tell the patient, yes, your mother or your sister or your wife has a problem with the carpal tunnel. I will do a little bit surgery and then she'll be fine. That was the way. You have not tested, you have not looked for, you didn't pay account to this palmar cutaneous branch. And actually the injury was here before entering into the wrist. So now there was a different modality. You could have said there is an injury to the nerve, I will try to repair it. It will take time. It needs rehab. But now the whole scenario got changed. You are diversified. Now patient understand, well, the problem is more and the recovery will be late. You want me to do it, but don't expect there is a miracle. Expect that it will be, I can assure you it will be there. But how long it will take, I cannot say myself. A year, 2 years, 3 years, I don't know. So it's all about the safety of the doctor. And how you can reach to the safety point if you are not aware of things of yourself, how you can predict the outcomes. Understand? So that's the important point. That's something where we have to intervene. Cutting and cutting and cutting is not the answer. A butcher can cut better than a surgeon. But butcher doesn't know when to cut and when not to cut. Surgeon knows the best surgeon. Who is the best surgeon? The one who knows when not to cut. Cutting is not the solution. So doing it scientifically, that is important. And that is your role and that is your job where you have to come in play. Is that clear so far? Okay, going further. These nerves so far. So now, Mohammed, what was your concern? What you said? You said something.
I was asking about time.
No, it was not the time. You saw your watch, then you gave a comment. Listen, you speak in a language which I don't understand. Do you want me to start a language which you don't understand? You want that to happen? Trust me, I'll do it. Once it happened with me. I was attending some seminar here and somebody, he was from US, but originally he was from one of the GCC country. He saw the crowd, he started in Arabic. We were 3-4 who are not, Arabic fine, communication you can do it, but scientific you will not understand. So we requested him that kindly switch the language. We are not able to understand. We are here to listen to you. You are a good scholar. We want to hear you. And he continued. He forgot. He lost. Fine. Nothing to be done. We were just sitting there and listening right and left what is happening. Fine. I decided to give him some lesson. So once he said, any questions? I said, yes, I have a question. I started putting up a question in my language. He said, I don't understand. I said, same, I don't understand what you taught. So you want that to happen? Trust me, I can start my language.
Nothing important.
No, but please say something which is audible to everybody. I appreciate. Is that clear?
Yes.
So now, thenar eminence. In thenar eminence, the first muscle here is the opponens pollicis. And now I'll putting up another muscle which is partially cut, designed this way, and that is my abductor pollicis brevis. And there you are looking at flexor pollicis brevis. So these three are the muscles who makes the thenar eminence. And now you can see that this recurrent branch from the median nerve, how it supplies these muscles, these three muscles. Is that clear?
Sir,
Yes.
the opponent pollicis is not very clear. How a muscle, just like on the back of the finger, can bring it towards it. Like muscles usually pull, right? So
Look,
this is anterior.
Mohammed, listen. This is a small area.
Yeah.
In smaller area, the actions are very precise. So just see that it is just a flat sheet. And most of these... Yes, Shabab. Maybe he is asking a very good question. So flexor retinaculum is the one which is responsible to give attachment, the proximal attachment to most of these thenar and hypothenar eminence muscles. So this flat sheet, opponens pollicis, its job is going and getting attached here. And the action of this muscle is to bring this thumb when I need this. So the muscle is going from here. Look at it. The muscle is going from here and getting attached here. Okay. When this muscle contract, it will bring it. Look at it. It bring it.
Yeah.
So this is opponens. Okay. This opponens who's here, it brings it here. So you can do this. This is opponens. This action is opponens. Now opponens is working. When I need to bring flexion, I can bring flexion. When I need to extend, I can extend. When I need to abduct, I can abduct. When I need to adduct, I can adduct. Got it? So muscles are arranged so much close way that it's not necessary that all muscle has to be like biceps, deltoid, and latissimus dorsi and trapezius. We had small, fine, short muscles. That's why they are for precise movements. That's why they are working for very fine and delicate type of movements. Is that clear?
Yes.
So now you are looking at the thenar eminence muscle, and all of these thenar eminence muscles, they were the opponens pollicis, flexor pollicis brevis, and abductor pollicis brevis, and their nerve supply was coming from median nerve through its recurrent branch, which was motor. Now coming to the hypothenar. Trust me, it's very easy to memorize the names of these muscles. They are just opposite to that. We learn opponents, flexor and abductor. They were pollicis. Now opponents and flexor and abductor, they are digiti minimi. So I have opponents digiti minimi, flexor digiti minimi and abductor digiti minimi. So now I have opponents digiti minimi. Next I have abductor digiti minimi and flexor digiti minimi. So these are my hypothenar muscles. And their nerve supply, remember, when we talk the nerve supply of the hand, I can say this way, all the muscles of the hand are innervated by ulnar nerve, except for few muscles. These few muscles are my thenar muscles and my two lumbricals. Thenar muscles are innervated by median nerve. My two lateral lumbricals are innervated by again median nerve. So I can say except for thenar and two radial lumbricals are innervated by median nerve, rest all is supplied by ulnar nerve. Is that right? Yes.
When you ask us about the innervation of, for example, the thenar muscle, do you say the median nerve or the
Well, if you say median nerve is acceptable, but if you can put recurrent branch of the medial nerve or motor branch of the median nerve, look, don't compare it with what I said to you guys before, posterior intraosseous. If I compare the weightage of posterior intraosseous with this recurrent, there is a big difference. Posterior intraosseous is the main branch and this is just a small motor branch. But if you write for the hand, there is an exception. For the hand you can write median, fine. Your answer is the best. There is no issue. If someone asks you, like in some question we put be specific. Once the word comes be specific, it means now you have to talk falan, falan, falan. Otherwise it's okay. But when someone asks you about the branches, supplies of the flexors, deep flexors or deep extensors, there you must be saying who's posterior intraosseous, who's anterior intraosseous, who's innervated by radial, and who must be innervated by ulnar, and whose must be innervated by median. So that is a different category. They are not comparable. They are not compatible.
So the anterior interosseous branch has nothing to do with the hand, right? It terminates at the...
It is for the deep structures.
The other end, the forearm.
Yeah. It is for the deeper thing. The main thing is going there. Because median nerve gives this branch, but median nerve never stops yet. It's not like radial nerve. Radial nerve, what happened to the radial nerve? Radial nerve gives, so it becomes superficial and deep. Deep one becomes posterior intraosseous, and superficial one, it goes in the hand and it gives branches there. So there is no muscle supplied by the radial nerve in the hand, because there is no motor fiber from the radial nerve reaching to the hand. But motor fibers from the median, motor fibers from the ulnar, sensory fibers from the median, sensory fibers from the ulnar, they are reaching to the hand. So radial nerve has no muscle dedicated to the hand. Is that clear? So now you can see that ulnar nerve, its superficial branch is supplying. The deep one is showing up here, and now here what is happening? Focus on the ulnar artery, and now you can see that superficial arch. My deep arch, what is its level? My deep arch is at the level of, it is very deep, yes, and it is at the base of my first carpo-metacarpal joint. And my superficial arch is at, can you see a web here? This web, like if you see that duck. Duck in his in feet there is something, because it helps in swimming. Otherwise chicken don't have any web, because chicken is not supposed to swim. Also
frogs.
Yeah, frogs, because they have to, anything who has to do something with water, who has to swim, is being provided by these webs, so they are helping in this propulsive movements. Got it?
Yeah.
So So these are the levels of my superficial arch, it lies here. My deep arch, it lies here. So you should be able to differentiate. So this superficial arch is not necessarily dependent on the contribution from the radial artery. Sometimes, and in some cadavers, you can see yourself, there is no contribution coming from the radial artery. Only the ulnar artery is the one who makes this superficial arch. Yes?
How can these eliminate the opposition? How does that work? I put all the thumb.
Okay. Can you bring this here? What is this action? No, forget. Hold your thumb. Do this. Is it flexion? What is this? This is opponents. They are going together. They are going to face each other. You do this after your count, when you want to count. And this you can do it. So they are opposing each other. This is the opposition brought by the opponents. So now this. So you understand now how this superficial arch is formed. Superficial arch is primarily made by the contribution of the ulnar artery. And the deeper arch is contributed by the radial artery. Right? In the deep arch, there is a necessity of contribution of the ulnar artery. But in superficial arch, radial artery may contribute or may not contribute, it hardly matters. And most of the time it is seen that only the ulnar artery is enough to create the superficial palmar arch. Now the superficial arch, which is visible to you, you can see that it starts giving branches. And these branches are common palmar digital arteries. And these common palmar digital arteries, and then there's a reinforcement, palmar metacarpal, and then there's an anastomosis with common palpal. They join together and they give common digital arteries. Well, if you don't know this cascade, don't kill your mind. Simply remember, the superficial palmar arch give digital arteries, and they are going to each digit. How and what is happening, just see that. Can you see that? For the second digit, third digit, fourth digit and fifth digit. These are proper palmar digital arteries. And all of them are emerging from the superficial palmar arch. Is that clear? Clear to everybody? This man is sleeping for quite long. Send him somewhere. Gentlemen, you want to sleep? I can tell you, there is one place, there is a bed there. You can go and enjoy and relax. Yeah.
In the clinic?
Obviously, there are so many places. We have beds there. Now, I'm not sending you. Said, I will send you to the cadaver place. So now, you have seen the contributions, the digital branches who are coming from superficial palmar arch. And before you have seen contribution. So you can see there that superficial palmar arch is not supplying to the index, to the thumb and to half of the index. It supplies everywhere else. Because where there is no supply, the superficial palmar arch goes there. Is that clear? Now, I am covering it with palmar aponeurosis. And you are looking at the tendon of palmaris longus. Now over this, you can see that the superficial branch which we learned, that was coming from the median nerve is showing up, supplying the skin. And then ulnar nerve is coming here. Now I am taking off these muscles and now here you go. Everything is gone in a bag and that is the skin which covers everything. Is that right? Now this is the skin which covers it. Now let's go to the final version of the hand. Here, let's establish, so this much part on the palmar supply, 3.5, you can see that 1, 2, 3.5, they are supplied by median nerve. And this half, the blue one, is by ulnar nerve. And this little bit radial. This is on the palmar surface of the hand. Now coming to the dorsal surface. Dorsal surface, 2.5 and 2.5, ulnar and radial. and this remaining part on the top by the median nerve. Is that right? So this you must be good with these two images. What is the nerve supply on the palmar surface and what is the nerve supply on the dorsal surface? Now, how we can test these nerves? By just doing one little action. Pin is too much, man. If you pin your patient, then he will pin you, not paying you. So pinch the index finger. That is a test for median nerve. If someone, and you do not to pinch it, because it's all about sensation. You touch it there, ask the patient, close your eyes, what is happening? He said, someone is touching my finger. That's it. Right? Now I want to check the ulnar. Just for the pinky, just give a sensation. You can find it. For the radial, just at the thumb. You can figure it out. So this is how you can test the cutaneous supply of these nerves. So if you are given a situation so and so involved in this type of injury and lost these sensations, how we check these sensations? No matter he has fractured his bone, he has dislocated his bones, but he has dislocated his joint, but by just touching and feeling little bit, not causing any movement, you can perceive that, okay, ulnar is fine. So far is coming here. If I get sensation here, it means my ulnar is still working. If you see an X-ray which is showing you fracture of medial epicondyle, you are suspecting, we were told, we learned that it might be associated with ulnar nerve injury. Now if I can see that, ask the patient what I'm doing, and if he say you are not doing anything, it means his ulnar nerve is not there because sensory fibers are gone. So my half of doubt is finished now. So I can, is it just a plain fracture? You explain to him and you do the useful thing, doable stuff. Right? So by just touch and feel gives you a lot, and no need to do really some painful procedures which added agony to your patient.
What about the rest of that? That's not innervated.
It is innervated.
But by which?
I give these circles to make your life easy. Yes. You want to rub, you can rub anywhere. No, but the perception is the same.
I know.
What is remaining in the hand? Tell me.
Yeah, this part.
This is not, do you call it hand, my dear? We call it wrist.
Yeah.
So now, if you want to be precise for that, this will not give you full information for some major. Cutaneous nerve can be damaged here, can be damaged there, but the main nerve survives. But this is the main continuation of the superficial things.
What about the lungs? Do they have anything to do with the muscles?
No. This is not a medical sort of question, and answer to it, I don't bother for that. Someone asked the same question today, and I said, when we were born, where we are not using our muscles, our fists were like that. See a newborn and look at his hand. So just keeping that might create these creases, and then the next question will be fingerprints, why they are different for everybody. Because this is from one who made us. So these lines, now these palmistry people, their whole bread and butter is with these lines. They tell you will die tomorrow, you will not be happy. They will tell you will be the rich man tomorrow, you will be more than happy. Got it?
But also I think genetic thing because...
Okay, I will give you time, you will give you a lecture for genetic things. I don't have time for my business. Guys, I put one slide here. This slide is just telling you what are the functions of the lumbricals. What are the functions of lumbricals and how this ulnar claw, it survives with this injury and what is the mechanism. Even if you are not clear, we'll talk about it. Now these two slides, just ignore it. They are not uploaded and you will not see them. This is for advanced movements occurring at different joints. I'm not touching it here. Have you seen the 6 fingers?
6 fingers.
Yeah, see, there is a lot there. But I don't want to bring it here. Now, this is our topic. This is our topic. We are looking at first carpometacarpal joint, and that joint is the main important joint. At the base of the thumb movements are important because, as I said before, if we minus thumb, a hand is no more functional. It's just any tactile organ. That's it. Nothing more can be achieved. So, no precision and no power. So now, we know the basis. About this joint, if you know that is a saddle type of joint, and what movements are occurring at these joints, all is depending on thumb, is all playing a role no matter what you're doing. And this is what exactly an example for a saddle thing. You are sitting on a horse. Again, now positions. Guys, these are images. These are pictures. 3D is not here. So we will learn together, we'll try to learn together the movements of the thumb. So you are looking at a normal hand. A hand who's not making any movement. Now this is a normal thing. So now I have to understand two axes. One goes this way, one goes that way. So the movements are occurring. What are the movements? The movements we have flexion, extension and abduction, adduction. And the fifth movement is opponents. So these 5 movements are there, which we need to be good at it. So now this movement in this axis. So the thumb, now see that this thumb is being brought towards the body because my axis was here. So thumb is being brought here. What is happening? Adduction. I'm taking it out. This is my normal position, neutral. This is more than that. Abduction. Got it? This is this axis. I told you there are 2 axes. Now this is one. You have seen adduction and abduction. Is that right? Now don't mix it now with other movements. The other movements are, so see that before I was moving like this, now I'm bending it. It's coming forward. It's looking. So this is flexion at carpometacarpal joint. This is flexion. Opposite of this is extension. So don't try to mix flexion, extension with the abduction. So they are, as I mentioned here, there are 2 different axes. These red lines are going in different direction. You are carrying out like this. This is abduction, adduction. You are doing like this. This is flexion, extension. Right? So this is the basis. And if you understand that, this is all needed. My 4 slides are just talking that. And we know opponents, bringing them together. So now another view, you are shown different movements, flexion, extension, abduction and adduction. Clear? Opponents. Now this is another view showing you the same activity. Now we talk about blood supply. Here you are looking at the deeper arch and the superficial arch. And see the deep arch, radial artery, how it contributes to the pollicis and partially to the index. The remaining are from their superficial artery. See how rich they are, and there are anastomosis at the pulps, and that distinguish once we have a cast, once someone is seriously ill, we look for capillary filling. There was an era, our old physicians, even today, they are not doctors, but they were famous. They just see the hand of the patient, they used to tell everything. And we are still amazed, oh, how good doctors were those. They never have any education of this type. They were making some herbal sort of things, and people are drinking, eating those, sour and bad taste stuff, and people are happy with them. Now, that era, what was the issue? Let's figure out in our today's era. Now, there are conditions related to the respiratory system and the cardiac system. If people are suffering, they have issues, and these nail beds in the hand, not clubbing. Nail beds in the hand and nail beds in the foot, they turns blue. You can see that you have a pinkish hue. But if it turns blue, that is called cyanosis. This cyanosis in the periphery. These are the peripheries. So we call it peripheral cyanosis. Now peripheral cyanosis, a smart guess which comes to my mind, this person is having some respiratory issue or some cardiac issue.
If I'm cold, this happens all the time.
That is different. In summer what happens? It turns Blue, it remains blue.
No.
And then the severity is different. So, and this is not, cyanosis is not only associated with blue color, like he mentioned clubbing. What is clubbing? You can see the nail bed, this angle deviates. So just looking at the fingers, you can say that this person is suffering from some cardiac problem or from respiratory problem. So simply, then you are looking at anemia can be figured here. So other things, so these were 3-4 main diseases at that time. They were able to distinguish and they were able to prescribe. Right? So you can see that how rich is that, and especially what was my point, when someone is wearing a cast after surgeries, it is always advised that do this, pinch your nail beds and look for the filling, and this is called capillary filling. You pinch it. Now this was peripheral cyanosis. Now in certain diseases there is central cyanosis. So Muhammad, you can say this turns blue in winter, but your lips turn blue, your tip of the nose turns blue. Then if it happens, then you are very, very near to having some sort of frostbite or something, some very severe type of cold must be there. Yes. So be aware. If it could have been sustained more, then they might have end up to chop off the fingers and chop off the things. Because if those who survive in extremes of temperature, like the places where the temperature goes -40 and all that, if you don't take precautionary measures, then you have there's a high incidence of frostbite, and then these people have been rushed to the emergencies, and the end result is amputation, cutting of the fingers, cutting of the foot, cutting of this and that. So the central part, if it has been manifesting, the tip of the toes turn blue, the lips turns blue. You can see that very pale looking face and the blue lips. So that indicates this person is suffering from severe type of cardiac or pulmonary type of problem. So then one can start thinking, by just looking at the patient, you have some clue, and then you start working on that. So this explains how richly, and we made a small cut, it bleeds profusely. So now these are the arteries, and now this is the level for the superficial arch. I told you the web of the thumb. And now this is the deep arch level. So just the proximal to the superficial arch, and is below, and the level goes for the joint level. Is that clear? So just the labeling of what we have learned so far. Any question, Tariq? So now you have seen the deeper arch, you have seen the superficial arch. There is something more, dorsal carpal arch. So this dorsal carpal arch is not on the palmar surface. This one is on the dorsal surface. This one is here. And how they are communicating, we'll establish here. We saw this image before, but now we are using it for the vessels. This is my deep palmar arch, and this is my superficial palmar arch. And this is my dorsal arch on the dorsum of the hand. And see that these are my palmar digital branches. Palmar metacarpal or digital whatsoever. And these are my dorsal digital branches. Clear?
Yes.
And now see what is happening. The superficial one is connecting to the deep and connecting to the dorsal. So there is establishment. There is a way out. If there is a problem with any of them, the other can take care of that issue. So there is a little bit overlap. Same is that you are going on takhasusi, there is a jam. You can flip to the Malik Fahad. You can flip to the backward. You can flip to the other roads, Abdul Aziz, by just going through some streets, and you can. So there are certain but alternatives, collaterals, the tours, tahwilat are there. So you can direct yourself, and you can get out of the rush areas, and you can redirect yourself. Right? So this happens, and this is exactly what happens with our vessels. So there are interconnection. When there is more crowd, those channels, people will surprise why traffic is going from in front of my home, because the main road is blocked. Correct? So these are the communication. But that makes us understand, and you can see the supplies from the deep arch going to these joints. Is that clear? Now coming here, we can see these type of veins on the dorsum of our hand. Why they are visible to us? Obviously they are there. These are the dorsal venous arch. And again in the cubital fossa, you can see these veins. We use them for putting our cannulas. Okay, fine, you have very good veins. I appreciate. I'll upload your picture. You like that? So, these veins. Now, are you having better than this? Or better than this? Show me. Yes, normal. Yeah, everything is fine. It's just image. So, these veins have used for giving injections. We know how to do it. Now, this is a little bit test, guys. Now you have to decide what type of movement is this. Now, what is happening? Is it a power grip or a precision grip? So fine, let's see power. What is next?
Precision.
What is this? Power and precision. You are holding a ball and you have to throw it.
That's biceps, not?
No, but this grip is power and precision. If you are just precise, when you move your hand, it can fall down. If you don't apply power here. And when you are throwing this ball, you are tricking this ball will not go straight. It moves. Have you seen people playing cricket?
No.
See it. Have you seen pitching in baseball?
Pitching?
Pitching in baseball? They, man, where are you?
I don't like watching sport. I like playing sport.
Okay, what sports you are playing? American football?
No.
Someone said for you. Mohammed will talk outside. Good, I like it. So this grip is the power and precision both, combination. Because you are holding a ball, fine, what muscle you are using, I'm not concerned. I'm concerned with the hand. You are holding the ball, but you are holding it very tight. And when you are throwing it, your fingers are flicking in between, so you are causing a movement. So this ball is not going straight, it's swinging. So it appears to you, it's coming to you, and then suddenly you see it moves like this, and it happens. And like, even you say you're playing football. Why? There are someone are very famous. Maradona, Messi and all that. When they hit the thing, it's not only powerful, it swings. There are angulations. There are so many others, my dear. But Mohammed, I like to see which club you play with. Manchester or United or where? Al Faisal club, good. No, Al Faisal is a good club. Okay, guys. So we have understand. Now coming to the middle row. So these are modification of precision because your object size is varying. Your object size is varying. So according to that, you're precising. Now coming down. This is prehension, a pincer type of grip. You are very precise. You want to be very particular. This is a pen grip. And this one is a hook grip. So there are different type of grips. Fine, if you don't know this, no problem. Nobody will put these things in the exam. This is for your understanding. This is for the application, how the grips, how the positions, how the position of the hand, it varies. Now here, there is a combination of power and precision. And one place you are providing a power, other place you are precising it. So at this place, you are showing power and here you are showing precision. Power is here, precision is there. So this is just to make you understand how these two movements are combining each other and how we can bring about these movements. Is that right? Now, this is not any nerve injury. There are certain other disease conditions where we can have certain problems. Nothing. These are nodules and other things, my dear. So what happens in these situations? When you get a patient, please always feel it a bit. Excuse me, my dear, something wrong? You continue, start talking. I thought you will be finishing up, but I can see that it's going on. Before you are showing him from your laptop, so we will be talking about it. Sabr. So there, my concern is when you see a patient, always when you're feeling a deformity, always feel it first. Everything is smooth, there is no roughness, there is nothing apparent. Because if a nerve is gone, something is not moving. But nothing will be extra there. But here, you can see something is elevated. There are certain nodules. There are some cord-like things. There are certain deformities. So, deformity can explain, fine, it is a deformity of a nerve is being not working. But nodule, no nerve is explaining. Something cord-like, no nerve has contribution to that. So, these are basically a very commonly occurring situation of a problem. Wow, I like it. Whose baby is that? Mine? I can imagine from you. You're a big man and you're such a small ball.
Yeah, that requires precision.
It's not even precision, very, pencil type of precision. So now, facial nodules, fibrous cords, and they are visible and they are palpable. So they are showing you some organic disease, some really underlying problems. So I'm just putting up these situations here just to enable you that you can differentiate these conditions from the nerve injury. Don't say this is lumbricals, don't say this is intraossei, but you should think a little bit different. This is for that purpose. I don't want you to learn. Now this is a typical hand. Any older person, she get or he get this sort of thing, and that is rheumatoid arthritis hand. And these deformities have their names. Z deformity and swan neck and all that. Now the message is what? By this picture, by putting this slide here, what is the message? Message is this. If someone have these problems, if someone has these diseases, if the situation has reached to this level, this is non-reversible. Nobody can revert it. No medicine, no surgery. So if someone has a problem of the small joints of the hand, be focused for that. He should be rehabilitated. He should be supported. Unless deformity occurs. Once deformity occurs, you cannot revert it. And this is, you can see very commonly some very older people who are suffering from rheumatoid arthritis, they will show you this sort of hand. And this is the worst type of example. And this is now unreversible, and this person is in continuous pain, deformed, cannot hold things, cannot perform things. So this was something which could have been prevented, but it was ignored. So hand of rheumatoid arthritis, what are the different joints involved? Well, this subject you'll be learning when you will be in year 3 and 4. Now, this we learn, hand of benediction. I gave you the slide. Learn through the lumbrical action, and then you will understand what is happening, why this is happening, ulnar and these claws. Now, be careful. You stick directly to something, your ball, it can happen. And you can see that common extensor tendon is gone. There is no precision now, there is sorrow and pain. All is gone. And now be more careful what I'm trying to show you next. Don't get into fights. Otherwise, you are hitting someone's face, but you broke your own finger. So be careful how strong is that face and how weak is your fingers. So just don't try to jump on everybody, otherwise you will be in trouble. Right? It can happen. Metacarpal. Now, don't pull someone from his collar. This can happen. Don't pull someone from, if someone is going and you are just catching him from the collar, you might see this going to happen. Profundus is gone. See? So be careful. And now again, what? So this situation? Ossification. Actually, this person was running and he put his hand in his collar, and the injury was too much that he was an avulsion of his, this tendon, and tendon is out. Surgery, my dear. You want to learn treatment? I'll take you through the process, but not now, not here. Now here, be careful. This is not the normal position of the thumb. See that? You have damaged things here. Can you see that? So now, anything which you think is bothering you still? Shh.
So if you go to the previous slide, we talked about osteoporosis and atherosclerosis. It can affect reflection.
This one?
No, before the Romson exercise. Yeah, this one. How does it affect reflection?
My dear, I told you about this slide. This I just put there for understanding. When we make our presentation, we don't target only year 1. There is a material for advanced years. So that is where it can be used. It's not for you guys.
So this will not come in the exam?
Never.
Neither rheumatoid arthritis.
Rheumatoid arthritis, you should know it, what is happening, but nobody will ask you what is the mechanism. Man, people are not able to answer this is metacarpal and this is phalanx. This is profundus or this is superficialis. If I put that much material, be ready next Sunday. So now we learn about this, we know about this fracture. Right? And now, that is the end of our hand.